So this is an IC on newer techniques or things which are cutting edge and new, which if you don't know, you're going to be left behind, whether it's surgical techniques or neo diagnostic techniques. So we'll start off with Dr. Alokesh Ganguly, a very senior consultant from Priyambada Birla Eye Institute in Kolkata, and his topic is on newer perimetry techniques. So the search for something new, something easier is always on. So there are certain techniques which have now come out which has made perimetry a bit easier. So with the help of the VR headsets or micro perimetry techniques, things have changed a little bit. So Dr. Alokesh is going to put light on this particular matter.
Thank you, Arijit, for asking me to be a part of this IC. So I'll be speaking on newer perimetry techniques. So what are the problems with the standard automated perimetry ones which we are used to use for such a long time? They are bulky, they hit a lot of space, they have limited portability, they are costly, and they need trained personnel to run it. Many patients have difficulty in concentrating throughout the test, and there are fixation losses which are consistently elevated after the third decade of life. There are false negatives which are elevated after the seventh decades. So there has been a continuous search for newer techniques like virtual perimetry, iPad perimetry, and microperimetry. So coming to the virtual reality perimetry, it is more suitable because it is cost saving, space saving, no need of trained staff, it is easier to use, it's binocular testing, no eye patches required, and less distraction. So we come to one of the offerings in this field, which is the C3 field analyzer, which is compact, can be conveniently used in screening camps. It is not required to wear an eye patch for this, and it is 5 times cheaper than SAP, and it has got a teleophthalmology enabled cloud-based diagnosis system. So the stimulus size is Goldman 3, and the test strategy is usually supra threshold. So the validation points are of most interest to us, and they show that while the CFA did not reliably identify deficits which match the HFA, it was moderately effective at identifying glaucoma subjects. So further refinements in this technique will perhaps be of value. The other option is the advanced vision analyzer, which is a small battery operated autoperimeter, but it does not require a separate dark room. The test strategies include 30-2, 24-2, and 10-2 strategies with full threshold and 4-wheel threshold testing too. This paper published in the American Academy of Ophthalmology journal shows that the AVA effectively captures the threshold values for each point in the visual field, and that adequate functional correlation suggests that there is a substantial equivalence between the HFA and the AVA. Another option is the Vivid Vision Perimeter, which is a software-driven product which runs on commercially available VR headsets, originally developed from the D'Amato Test 21, in which the patients interestingly can move their heads and eyes during the test. The maximum luminance is the ocular rift is around 250 apostolbs. Default perimetry test is similar to a traditional 24-2. Average testing time is 10 minutes per eye. So in this ARVO publication, it showed that the VVF platform provides reproducible visual field sensitivity measurements for glaucoma patients, and these data suggests that this VVF measurement repeatability is very much consistent with the SAP. The IMO perimeter is another option which can be used anywhere, including a patient's bedside or wheelchair. For moribund patients, this can be of great value, with spherical lens equivalent corrections enabled up to -9 or +3 diopters, and it also allows for astigmatic correction. So the test strategies are 30-2, 24-2, 10-2 programs. Mean deviations, pattern standard deviation, and visual field index are all calculated. The EMO reduced measurement time by about 30%, and the VFI and the MD values were highly correlated with the HVA, and therefore it is definitely of value in moribund patients. The visual field analyzer, which is a lightweight device, and it comes in 2 versions, office or home used. It's a head mounted device with a Bluetooth enabled response, and there is a cloud based report storage system. So it can also test full threshold strategies as fast as 4 minutes per eye, with the 24-2, 10-2, and 30-2 all available. And there are studies which show that there is excellent correlation between this and the SAP in normal and glaucoma patients, and visual shows a high diagnostic performance. Coming to the other modules, which are the tablet perimetries, is the iPad Visual Fields Easy app. This app is free, available on the net, but it tests about 96 visual locations in the central 30 degrees with a size 5 target, but it is not as suitable for rapid screening or for mass screening programs of glaucoma because it has a high number of false positives, and then specificities you can see here as highlighted. So the Melbourne rapid fire test was developed by the same research group with full threshold and screening modes. It is testing fields which are equivalent to the 24-2 program. The patient wears the near correction, central fields are tested, and the peripheral field is also tested to cover the entire 30-degree fixation changes during the testing, as you can see here. So there are 9 zones with 32 test spots for the Melbourne Rapid Fields test and 54 tests for the Humphreys Field Analyzer, as you can see here. And this is the printout of the EMO. The change in fixation points 4 times to these multiple fixation shifts, and they contribute to the increased variability in the threshold. Malalignment and tilting are a problem with this screen. Sensitivity and specificity are quite high as compared with the HVA, but not above 90%. So the lack of internal strength in rural areas for transmission of the internet are questionable in the detection of early cases, and this may be a drawback in the MRF fields. Another variant is the Peristat online perimetry. It is a standalone visual acuity test along with a calibrated visual field test. It can test up to 24 degrees of the visual field along with mapping of the contrast sensitivity. It has a sensitivity for mild to severe HVF defects which were exceeding 80% with specificity around 94%. It is unable to register very early field defects, so screening may be issue there. So advantages of the iPad perimetry are that it can allow for more data points, it's less time consuming, so it reduces fatigue in the elderly and debilitated patients. So the disadvantage was this, that suprathreshold perimetry using the VFE is not suitable as a rapid screening tool for mass screening of glaucoma. It cannot be a substitute for the Humphreys visual field analyzer. Coming to one last interesting development, which is the microperimetry, in which basically it is controlled as a fundus controlled perimetry. It is a visual field test that incorporates perimetry and retinal imaging together. So correlation of the visual information with the structural and anatomical data is also correlated here. It is important for testing some retinal diseases that initially spare the central retina. They allow for photoreceptor specific testing through implementation of the dark adapted chromatic photopic testing. So it is indicated for the early diagnosis of some pathologies like the AMD, the hereditary retinal dystrophies, the macular hole, macular edema due to diabetic retinopathy, etc. As you can see here, there is the fundus photograph, and this is imposed on it is imposed the visual field. This microperimetry projects a light stimuli on the different points of the retina, performs a fixation analysis, and combined with the real-time fundus imaging using the scanning laser or ophthalmoscopy, it continuously tracks the eye in the real time. And after completion, this grid is superimposed on the retinal image, which facilitates evaluation of the region of interest. So it's a psychophysical method which is rapid, safe, and non-invasive. It is a spatially resolved testing of visual sensitivity. Reliability and ability to detect a change is evident for multiple retinal diseases. So it can be used in glaucoma. Detection of nerve fiber layer defects and eccentric fixation in advanced glaucoma can perhaps be increased with this test. So these are the pictorial depictions of the microperimetry, but the limitations are there. As with most diagnostic tests, you need patient cooperation. It relies on the patients. The greater percentage of false negative and positive happens in this test, affects its reliability. In the long run, it does trigger the fatigue. Thank you for your patient listening.
Thank you so much, Olukrishna, for this wonderful talk. Just a quick question: like, has anyone ever tried anything? The VR headsets, microperimetry. Has anybody tried on?
We have indigenous iPad based visual field. So I've done that, and we are doing it for a lot of our patients. You largely see the same pattern that you see on of the defect that you see on the HFA. So that works well. So it's difficult. It's a good screening tool, is what I can say. Studying, looking at progression and test retest variability is something that is happening. I think we are a little distance away from that. On iPad based, yes. So I,
So that the one which you have in the marketing team is doing that for your hospital. How good is that? The one which is the Humphrey pattern which you have.
So I am not with the group which is looking at, so I have not looked at the data. But when I've tried it personally is what Arijit does. So it shows the same pattern because I sent some patients for these tests which are being included in the study. So if you see an incomplete superior
This is a
arcuate defect, that
duplicate
is what
wire.
the iPad also shows. So how
It's a
good is that
duplicate
is
wire,
something
this one.
will require study, and please just don't go by my words. Look at, wait for the publication.
And also one particular problem that I personally, I've tried the VR headset, and there is a background luminance. So it's not that it's a, non-illuminated background. It is an illuminated background on which you get to see these flashes. So it creates a sort of weird effect. It's said that it's easier, but I personally I felt it's more difficult. It was creating a sort of something that I felt was abnormal. The
Which one?
luminance itself. So there's a background luminance. So on top of that, you're seeing these flashes. So it creates a different sort of a feel
Okay.
from the ones that we are accustomed to. To probably it's something to get used to. But maybe the newer generation, maybe that would be the way to go.
Uh, you are right, but what? But then, if you can just give a real comfort for the patient, and that's going to be the reasonable amount results you can have than with your regular perimetry. I have done multiple times the regular perimetry, which I found it very uncomfortable. Doing a full threshold is almost not possible anymore. Even doing the top in octopus is also, I'm finding it difficult. It is not that easy, especially when you cross 40s and 50s. That it's not easy. The comfort, you have your back pain, all that, you can just lie down and do your virtual perimetry. But at this moment of time, some of us are still not willing to accept the virtual perimetry is doing a good job. For me, I feel it is really doing a good job. And there is a issue on people start complaining about whether that has a follow-up things. It does have its own follow-up things. We are just at present mentally we are not willing to accept it. That's what my feeling is. Though there are multiple studies, but I feel it is the way that possibly in the future things will go. You have 20 lakhs, 30 lakhs, 40 lakhs. You have it for 4 lakhs, 5 lakhs. Even patient is more comfortable. Anyway, so I'll just
So we'll move on to the next talk from one of my mentors, Dr. Satyen sir. So I met Satyen sir long time ago when he was attached to Arvind Coimbatore. He's gradually moved on and he has his own setup. And sir has very unique takes on various things, be it gonioscopy, be it NCT, be it SLT. So I would just like to know sir's take on SLT in today's practice. It's something, it's a very controversial topic. Some say it's extremely good, some say it's not good at all. So I just would like to know what is the role of SLT today in the Indian scenario.
okay. Fine. Thanks, Ajit. I have no connections with any of the industries, the company, whichever I'm talking about. Of course, we all know that as we are having only a glaucoma people here, I'm not going to, dwell with too much of this, but I'll just give you the brief of it. Again, for me, we are all kind of, I would rather use this word itself. We are adamant in not accepting few, truths. The patient adherence and persistence, we all know that it is quite poor in glaucoma. Like 90% of them are not adherent to their medications. And of course, the persistent is going to be another question. When we did the study on the follow-up, these are all the problems that they have. Lack of knowledge seems to be a big thing. That is, when I was at Arvind, we did the study. And so there are a lot of issues the patient has in following up the either follow up or for the medication usage, everything. There is a very common thing which we really look at is the most of the patients miss some drops, some miss most drops, and few miss all drops. That is in US context, but there is a reversal in our own context. See, after the second bottle or the third bottle, the purchase of medications, we think they are buying. It is not the truth. So there are many reasons. We don't want to go into that all those things now. This mechanism of SLT. This is one of the most commonly used slide ever you can see. The SLT uses the Q switched 3 nanosecond pulse frequency double ND ARG 532 wavelength green laser. And earlier, when we started the SLT, the beam size used to be a little smaller, thinking that we have to really focus on only a small area. But then over a period of time, the companies evolved with a larger size so that we can easily shoot the trabecular meshwork comfortably. And mechanism of action is the laser energy selectively targets the pigmented trabecular meshwork, the endothelial cells with no coagulative damage. I don't want to again go into this all these theories. So how does it really work as a primary therapy? So we say it is as efficacious as the PGA. We are not looking at the other PGA. The comparison is only on the lateroprost. So it really compares with the lateroprost. Whatever I'm talking about is these are all virgin eyes. It's all not been treated earlier. So the virgin eyes, the SLT works perfectly all right. Is the luminous works, is the LX works, or other machines works? For me, I've used all that machines. For me, the Apasami works much better. I really don't know the reason, but the reason when I went back and assessed, the only reason I could say is this could possibly because of the super Gaussian curve. They use it in their machines in the lasers. All the machines they use the super Gaussian mode in their laser machine. So that could possibly be the cause. I don't know why the Apasami machine should work much better than the other machine. I could only theoretically I could see only this possibility. So this one thing as the primary therapy we know that definitely it is either equivalent or probably little lesser over a period of time. It may work. So this is the long term, like 5 years. People keep saying that is it for an year, like we talk about the mix for an year or two. But now we have the 5 years data is definitely it works for 5 years. Many of them provided there's a controversy as you are mentioning about the controversy. Controversy is if you think the Swalby's line as a pigmented trabecular meshwork, and then you try to do the SLT, you don't get any result. Doing a proper gonioscopy, understanding about the gonial lens and doing the proper gonioscopy makes all the difference. So people should do a proper gonioscopy, do it properly, then you definitely will have a good result. So one of the doctors who was really saying the controversial things about the SLT, I just went and asked him how many lasers you have done. He said, no, Satyan, I haven't done anything. People are saying that they didn't get the good results. And I asked who are all the persons. Then there's a few more doctors. Then I asked them also. They also said, no, we have just studied somewhere. So that is how the things are. We have to be a little cautious about how things are done. So 93% of the success rate if you take the medication, for example, timolol, probably it works for only about 70 to 75% of the people. The remaining 25%, it doesn't respond. It is not that medication works for everybody. Similarly, SLT may not work for everybody. As an adjunctive therapy, patients are on medication. You got to stop the medication before you do the SLT. There's always a feel factor that once I stop, what happens in the next couple of weeks? Nothing happens. Even if it goes to 30, nothing happens because the patient was not using medication for many days, many years. So 2 weeks or 3 weeks of not using the medication, it may be having some effect, but it is not going to blind the patient overnight. So definitely it has an effect of around 3 to 4 millimeter of IOP drop. And we all know that the fluctuations are one of the main reasons for the progression of the disease. But then when you do the surgery and SLT seem to have a flattening effect on the IOP fluctuations. That is where it really helps to an extent. And as a replacement therapy, this is how it works. Like if the patient is on one medication, you can probably take off the completely about in 86%, and then you can see if the patient is on 4 medications, 32% of them can be reduced with 1 or 2 more medications. So let me just show you the Indian context. I'll just okay. So what are the main side effects that we have faced is never do SLT below 50 years. If you are going to do that, you are going to burn your fingers. Which patient, I don't know. We are going to burn our fingers. But below 50 years, somehow they all have a high IOP spikes. It's better not to do. They'll have a blurred vision, but most of them will be okay. But applying the steroids immediately after the SLT is the one thing which you should not be doing it. Once you do that, then it will not work well. Main indication is, of course, the primary open angle glaucoma is the best to have with the nice wide open angles. All primary open angle glaucomas, we have to compulsorily avoid in uveitic, aphakic, NVG. All these patients you will have to avoid because it will never work. Probably it is going to be more harmful. Pseudophakic glaucoma in aphakias, young ones, pigmented glaucomas, again it is, at least in my hands, it is doesn't work as good as in other primary open angle glaucomas. So we will just, this is a major clinical, I'll just go through this study. So there were 600 patients were included in our trial. That is one of the major trials when the Luminous was launched. At 4 centers we did the trial. So it is 150 patients per center. And unfortunately, I came out after a few days of the trial was started. I think George has published the article after some time. So when I just was there, it was 48 patients who were completed on the study. And these are the results. About 23% of them had IOP drop, had the first day, and then 3 months post laser. This is how the IOP reductions were. But then over a period of time, again, we saw that the IOP drop was more sustainable. The problem again with the machine is the Luminous machine I'm talking about. It is very difficult to do because the head is very complicated head. Upper machine is as easy as how you do with your YAG laser, YAG capsulotomy or PI. So whatever the lessons I learned is, don't overdo things. Don't tell the patient that you're going to really completely treat his glaucoma. They have to come back for a follow-up, good counseling. And there are non-responders. You may think you just do it, and then if the patient is not responding, whether you can go for laser next week, don't do that. But once they are responding, and if you feel it is not adequately controlling the intraocular pressures, you take them up after 2 months. That is the best time where you can really do the repeat lasers where they were responding to your treatment earlier. Otherwise, it is not going to work. So this is the lesson again I have learned is seen in 10% of the patients. Younger ones are the ones, many of them, including some of the doctors whom we are treating now with the trap, they don't just respond. So it is very difficult to control the intraocular pressures in those patients where they had IOP spikes, especially the young ones. So do not overpromise. Choose elderly patients. Primary treatment works best. Choose retreatments only in responsive patients. Some of them, they do have this question of either I do 180 or 360. You got to go for 360. There is no 180 in this. Thank you.
Thank you so much. Thank you so much,
So I
Satyan sir.
just thought I'll give you some practical points rather than just talking some theory for you.
Yeah. And
Because all of you are good in theory here.
yeah.
I got this luminous machine for demo purpose.
I'm not against Luminous. If you want
Sir,
one, I'll give you that
I'm
my
just,
machine also.
saying that, sir, in our scenario, we have done around 10 cases. Out of them, 6 responded. So it's not that it doesn't work. Sometimes it works, and as you said very clearly, sir, we do not have to overpromise that this is something which would basically take care of everything. So you have to be very sir, in few of my patients, I am doing a follow for last 4 years, and their pressures are not going above 12 millimeter of mercury. So it sometimes works very well.
The other trick I can give you is don't do those who are having less than 22.
Okay, sir.
Okay, NTGs and all will never work. The ideal is higher the IOP, better the results. 25, 27, 30, 35, they will all respond beautifully.
Sir, in many of my patients, as you have said that it should not be done or avoid doing it in more than 50 years. Many of the patients who are
Not more than 50, less than 50 years.
Okay,
Less than 50.
Okay, sorry.
More than 50 years, of course, obviously you'll have to. Yes,
Sir,
madam.
No, sir, in the young patients also it was working in trauma and treatment.
It works. It is all anecdotes that we are talking about. When you do a little larger volume, and then you'll start understanding whether it really works. Some patients, if it works, it works. I'm not denying that fact.
No harm, sir. At least you can give a try.
For me, I will not touch because I've burnt my hands. So I will not touch in those with the traumatic eyes, younger ones, because we are going through, even after 15 years, I'm going through that phase of unable to manage them. We have done a trap, we have done a repeat trap, we have done everything possible, tubes, psychology, CPC. I mean, one patient I put two tubes are there. So once they are having a high IOP, it is extremely difficult to manage them.
yes, sir. I had some experience of doing about 38 patients whom we followed up for 2 years, which were post PKP with adequate visualization. But as you were saying, around 6 of them for 1.5 years or almost 2 years till we studied. The significance was this, that we could put them off, instead of 3 glaucoma drops, we could come back to 1 glaucoma drop. So even if it is percentage wise less, sir, but it makes a lot of difference.
Alakesh, nothing is wrong. As long as it works, it's fine. But whatever we are talking here is what is the real good indications where you can expect a good reasonable amount of results. These out of the box patients, yes. If you feel it is working, it is working. I'm not denying that fact. But can we just openly say at the podium you do in every patient and you have a result? That's what the concern for me. I can't openly say that you do in every given patient.
Absolute contraindication is only when you have done a 360-degree gag. Otherwise, you can do anywhere. What sir is saying are probably established recommendations for best case scenarios.
So when you are staging in the AIOS podium and then saying that you do in every case and then you'll get a result is not the ideal way to do things.
Sir, considering open angles, now with micropulse laser also being available, which patient would you choose for what? Now the options are so much more.
Micropulse is completely different, doctor.
Yes. Open
Micropulse we are
angles-
not looking at for either open angle or angle closure,
Yes, sir.
nothing.
So open angle glaucoma
You are
on
talking
2 or
about the
3
MP3. You are
medications.
talking about the MP3, right?
Yes.
Okay.
Would you
MP3,
choose micropulse or SLT?
I think both are completely two different things, which we are not even comparing.
No, sir. What would you offer the patient if you had both the options?
No, that's what I'm saying.
Yes.
The indications for micropulse is different as a primary therapy, and for the SLT is completely different. We are not going to do in those eyes where 35, 40 or 45, we are not going to do SLT. Those patients I will definitely go for a micropulse, because micropulse is one thing where you must understand we can reduce the intraocular pressure, but it is not sustainable. You will have to go for either a repeat procedure, either one time or 2 times. Then it works. The second probe, the type 2 probe will not work in any patient. So we had a discussion that they have to change the probe. They are willing to change it. They're willing to give it for the trial for probably next month we'll start it. But the second probe is completely not working.
Yes, sir.
The first probe is working, but for economical reasons, for Indian context, they are not willing to give it to us. But then second probe, 0 results in all the centers. All the centers. So I just told them very point blank, you have cheated us. You make sure that either we take you to the court, and when you are saying something, some settings, and if it is not working, that is your mistake. So you got to replace the probes, or you do the first trial and then come out with some settings, parameters, which one works. If it doesn't work, you change the probe, that's it. So it is very harsh talk. Yesterday we had the company. So they are also willing to talk. So initially they said, no, in US it is working. Don't lie. Let me talk to the people in US. But then they said, no, they are also having difficulties. But you know how they speak. But we don't have to really completely take away. But SLT is one thing, doctor. Up to 35, definitely you can look at doing the SLT. As I told you, is it the super Gaussian mode in the upper semi machine is working much better? I really don't know, which I'll need to kind of go through it and see.
Another thing I want to ask you that post SLT, what is your normal
No medicine. Unless the patient says that I'm not comfortable. But if you give the anti-inflammatory or steroids, then the response is, yeah, you need to allow that to have at least minimal inflammatory response is really required. Too higher an IOP, of course, you can give a Diamox, don't put them on topicals. Yeah.
Thank you so
Thank
much,
you, Ajit.
Satyan. I just wish there were more people in the hall because they would have benefited from this particular discussion. We would have. Thank you
Yeah,
so much.
thank you so
Thank you
much.
so much.
Your hall has little bit more number of people than what I had there, so no worries.
छोड़ दो यहाँ से वहाँ से नहीं
Settings, and if it is not working, that is your mistake. So you got to replace the probes, or you do the first trial and then come out with some settings, parameters, which one works. If it doesn't work, you change the probe, that's it. So it is very harsh talk. Yesterday we had the company, so they are also willing to talk. So initially they said, no, in US it is working, don't lie, let me talk to the people in US. But then they said, no, they are also having difficulties, but you know how they speak. But we don't have to really completely take away. But SLT is one thing, doctor. Up to 35, definitely you can look at doing the SLT. As I told you, is it the super Gaussian mode in the upper semi machine is working much better? I really don't know, which I'll need to kind of go through it and see.
Another thing I want to ask you that post SLT, what is your normal
No medicine. Unless the patient says that I'm not comfortable. But if you give the anti-inflammatory or steroids, then the response is, yeah, you need to allow that to have at least minimal inflammatory response is really required. Too higher an IOP, of course, you can give a Diamox, don't put them on topicals. Yeah.
Thank you so
Thank
much,
you, Ajit.
Satyan. I just wish there were more people in the hall because they would have benefited from this particular discussion. We would have. Thank you
Yeah,
so much.
thank you so
Thank you
much.
so much.
Your hall has little bit more number of people than what I had there, so no worries.
यहीं से खोल छोड़ दो यहाँ से वहाँ से नहीं
Which is about the sustained drug release system. So, the newer modes of drug delivery, basically. So, now the issue is with adherence, persistence, compliance, etc. So, there are a lot of these newer techniques of drug delivery. For example, punctal, subconjunctival, anterior subtenons, suprachoroidal, posterior subtenons, even subretinal, intrascleral, and phonics delivery systems. Now, there are these technologies which are now booming. One is something referred to as 3D printing, and the other is nanotech. So, these are not new technologies, these have been there for years, for 30 years or 25 years. But what is happening is, with the evolution of these technologies, now they are at a stage where they can be used for the eye. So, because you have 3D printing, you have developed these drug delivery systems where the drugs can be delivered intracamerally or subconjunctivally or in the punctal spaces. And MIGS owes its success to the 3D printing, because almost all these systems that you have, they have used 3D printing technology. So in case of these patients who are a vast number, the early glaucoma cases who are on monotherapy, you can have these delivery systems, the subconj, punctal, or the external ocular inserts. And for patients on multiple drops, you can have these sustained intraocular drug releases. So it caters to both. For example, the early glaucoma cases, you can use these. And for the moderate to the advanced glaucoma cases, you can use these so that you can reduce the number of topical meds. So let's look at, I'll just quickly run through these 7 systems. 1, the external ocular inserts. 2, the punctal drug delivery systems. 3, drug-eluting contact lenses. 4, microneedles. 5, subconj implants. 6, nanoparticles. And last, the intraocular inserts or the implants. So the external ocular inserts, they have been there for a long time. So one of the earliest ones was something called OcuCert, which used to deliver pilocarpine. So it was either 20 micrograms per hour release for 7 days or a 40 microgram per hour release for 7 days. Apart from that, we are all familiar with the bimatoprost ring and something known as the topical ophthalmic drug delivery device, or TODD. So it's basically like a contact lens. However, it doesn't sit on the cornea. It is placed in the fornix and it can be impregnated with a drug, for example, 3 milligrams of timolol and 600 micrograms of latanoprost. So these give you a long-term sustained drug delivery. Something else called NODs. These are the newer ophthalmic delivery systems where you have a handle, paper and a film, and the segment which contains the drug, it detaches from the carrier and gradually dissolves, releasing the drug. So you have the advantage of a preservative-free drug with a longer corneal contact time. This is something called SODI, which was developed by the Soviet scientists, cosmonauts, who could not use the drops in weightless conditions. So these release the drug either by diffusion or osmosis or bioerosion. And you have these newer things which are called micro machines. So these are referred to as micro electromechanical systems. So these are again currently in the phase 2A trials. So what you have is, you have a small drug reservoir and you have these wireless heating coils and a thermal sensitive hydrogel. So the drug remains here. When the heating elements are activated, the hydrogel valve contracts and the drug is released. So basically you have this, thank you Dipanjanda for coming. So you have this drug delivery system, the small machine which is fitted on top of the sclera, and you have the drug delivery inside the eye. So it can be auto-regulated with the help of your mobile phone, or you can have it manually. The next group, the second group, are the punctal drug delivery systems. Now things are moving so rapidly. So there were these 2 companies which were there. One is by Ocular Therapeutics, which used to manufacture OTX-TP, which released travoprost. The other is by the company called Marty Therapeutics, which manufactures Evolute OR. However, surprisingly, Ocular Therapeutics has discontinued this. So basically now the only one you have is the Marty Therapeutic Delivery System. So what was there in the Ocular Therapeutics was a hydrogel. So you have a small hydrogel which was implanted into the punctum and it gradually released the drug into the tear film. The Evolute by Marty Therapeutics, basically what this has is a drug-eluting core, and you have this proprietary plug. So this plug allows the flow of tears into the NLD, and the drug has a one-way valve to extrude into the tear film. So this is something which Marty is really working on, and it's not just about glaucoma drugs. So you have Evolute Allergy, you have Evolute Anti-Inflammatory. So in post-cataract surgery cases, probably you won't be needing drops in the future. In allergy cases where you need a sustained delivery, probably something like this could work all through the day. Drug-eluting contact lens, again, nothing new. You can have a lot of varieties. You can either have a soak and release, where a polymer is there which has the drug impregnated in it. It will gradually release the drug. 2, you can have a film impregnation contact lenses with molecular imprinting. 3, you can have an enzyme triggered drug release, for example, timolol and lysozyme. And 4, you can have the nanoparticle loaded contact lenses, which gradually elute the drug. So this is the contact lens drug mode. Something a little bit new is called microneedle drug delivery system. So these are basically used for drug delivery to the skin. So patches on the skin. So you can have silicon, glass, metal, ceramic, sugar, or polymer microneedles. For the use in the eye, what you have are these detachable microneedles. So basically, it attaches onto the surface of the cornea, and then the core remains. Either the whole needle remains or just the covering of the needle remains, and gradually it elutes the drug on the surface. You have 2 companies which are manufacturing subconjunctival implants. One is a company called BioLite, which has a product called ID. So this gradually releases latanoprost over a 12-week period. And the other is a company called Greybug. Now, the Greybug is a giant. We look at the shares of Greybug, those who are interested in shares. It is doing a lot of work on AI and these subconj implants, so something new. So basically, what it is doing is it implants a pro-drug, which gradually becomes a drug. So you can have either a IOP-lowering drug and an IOP-lowering drug combo, or an IOP-lowering drug and a neuroprotective drug combo. So these are subconj implants. Again, nanoparticles, like I mentioned, it's nothing new. It's been there for around 25 years. So you have these nano drug delivery systems where either the drug is entrapped as a nanoparticle, or it's an encapsulated nanoparticle, or you have these neosomes, or you have these dendrimers. So these are sustained drug release preparations. You already, a lot of people may be using latoprost RT, which is actually this, a drug-loaded liposome. So it kind of gradually enhances the drug delivery. So you have these brinzolamide loaded nanoparticles, or you have these liposomal latanoprost. So something which we use in cooking, which is the black cumin seeds. So there is a particular drug in it which is called thymoquinone. So now some of the companies, they are having liposomal latanoprost or liposomal thymoquinone, or a combination, latanoprost and a thymoquinone combination. So these are basically injected subconjunctivally. So you inject them, it remains for 90 days, gradually elutes the drug. So what they say is that the hyperemia, etc., are less when compared to a person on topical latanoprost for 90 days. And last but not the least are the intraocular implants. Like I said, print technology or 3D printing, it has enabled us to have these molds. So you can have these drug molds have deliver these particles, and you have these injectable systems where it puts the drug into the intracameral space, and gradually the drug elutes over a period of time. So this is a company called Envisia, which manufactures something called ENV15, which is a travoprost. You have a drug from Glaucos. The only difference with the drug from Glaucos is it's a titanium implant. So here, the drug is gradually released. You have to remove the implant, and you have to re-implant a fresh drug after a 6-month period. You have the bimatoprost SR, which is the Durista, which at the moment, the Durista has been FDA approved. It got the FDA approval on 5th March 2020. So it's a pellet designed to release bimatoprost over a 4 to 6 month period. So a lot of studies have been published showing pretty good results. And like I mentioned before, Ocular Therapeutics, which has the punctal delivery system also, they are coming out with a number of drug delivery systems which are intracameral, be it in ARMD, be it in glaucoma, be it in dry eye, be it in ocular allergy. So basically you implant the pellet, gradually over time the pellet is going to reabsorb because it's a biodegradable implant. So all these newer drug delivery systems, be it external ocular inserts like the bimatoprost ring, the punctal drug delivery systems, the drug-eluting contact lenses, microneedles, subconj implants from Greybug or BioLite, nanoparticles, or intraocular inserts, all these are going to play a big role in the near future. Thank you. So I'll directly move on to the next talk by Vineet. So, I when I was putting this IC together, I put up these minds from different parts of the country Vineet is a fresh, young mind, and he's doing a phenomenal work. Be it on ocular blood flow, be it Vineet is the one who inspired us to to get the MP3 laser. But then, like Satya sir was mentioning, things, problems crop up. So there are issues. So I would like Vineet to come forward and have his presentation on these lasers.
So sir, जब तक till it is connected. So the topic that I would be speaking was about is micropulse laser and endocytophotocoagulation as game changers. So actually, are these game changers, or they are just supplements, or the last thing that which we can do? So most of these patients which we are doing, so these are that they have already undergone TRAP, they have already undergone GDD, post PK. In the COVID times, we are scared to go for surgeries. The patients were more scared to get the surgeries done. So in all these cases, so I would say it's not actually a game changer. According to me, it is something which can just buy you time. So before going for a surgery in a GDD or anything else, you can at least buy time. You can get a 5 to 10 millimeter pressure control or 15 to 20 millimeter pressure control. The recent patient that I did, he was referred to me by her sir. So the patient wants to get the micropulse laser done because he was not very keen to get the GDD done because his marriage was on 5th of May. So he just wanted that, sir, 15, 20 days, 30 days, 35 days, whatever is the period, I can have just 2 millimeter, 3 millimeter pressure control, and then when everything goes back, because we also know that maybe 15, 20 days, but unfortunately even one day the pressure was not down, so it was same. So would be talking about the micropulse laser and endocytophotocoagulation. So first of all, why we need it? As we basically told, that we need something which has a good safety profile and which is free from the incisional surgeries. So if we want to delay the incisional surgeries for some time, we can definitely do that. How the micropulse works? So there are a lot of things theoretically. Practically, I would say that it basically increases the outflow mechanisms, and that too uveoscleral. So in which patient we can do it? Actually, we can do it in almost all the patients. I have not tried it in any of the patient of the congenital glaucoma, and the youngest one we have done is the steroid induced glaucoma, VKC patient, a child of 15 years of age. So actually we can do it in any of the patient preoperatively, the same things that we want in a patient where we have to go for any laser. So one of the patient, he was having a uncontrolled blood sugar 360, 430, 450 with a pressures of 28, 30 PDR also. So in that case, the thing is, we cannot go for a invasive surgery. So we said that till you are going to decrease your blood sugar level, can we do this? So in that case also we can do. So very easy for this maintaining and this setup, this machine by the ARIJIT. The only thing is that we have now two probes, the earlier probe which was having different settings and the new probe that is having different settings. So in the earlier probe, we were having a setting of 2000 with 80 seconds, and the new one that is having a 2500. So anesthesia, most of these patients, we have given the periburbal block in 2 or 3 of the patients where we have just used lignocaine gel and the paracaine. So the patient is having a pain. So because we are touching the ciliary body and we are slightly painting type of patient. So and the thing is that we are not having, because the machine stops after 80 seconds. So it is in the one time you do not have any scope of error. So actually it is not very easy, because it was earlier propagated that it's very easy to do that, because you have to just be 2 millimeter and you do not know whether at 2 millimeter you are having a ciliary body or not. So you do not have a retake option here, because whatever you have done, it is done, and you cannot actually titrate like in any invasive surgery or anywhere else. You know that the pressures are coming down or whatever it is going on. In micropulse laser, it's a total blind procedure. You have to just trust the god and the makers that it is working or not working. Same thing which we do in a DLCP, avoid the 3 o'clock and 9 o'clock. Procedure is very much the same. Only thing is, get a good viscoelastic cover and then basically put the probe, because you need a media through which the laser can penetrate. The earlier probes were like this one. So we have a notch there, and if this is the limbus, so we should be around 2 millimeter from the limbus. And another technique was that you can visualize the ciliary body if you have a retina setup with you with the use of illuminator. So you can see that where is the ciliary body, and you can basically point your probe like this. The new probe is that we to put it over the limbus. So this is the difference between the new probe and the old probe. And one thing is that in the old probe, there was, because Indian eyes are usually smaller eyes, so one technique is, because they must have got a trab or anything done previously, so you can have a traction suture also in the cornea, so that you can have a good exposure. Because when you go to the inferior nasal side with this probe, usually it stuck to your speculum, so you do not have any chance to do retake. So that is the most important thing. So you can at least have one corneal traction suture done, and then just pull the eye towards the area which you want to do it. The new probe, you can do a quadrant technique also. So they basically recommend it as a quadrant technique, but in the old probe also you can do a quadrant technique. Post-operative regimen, it is almost the same which we use, but I usually give a hometropine also after my 50 of the cases, because lot of these patients, they are having a bit of anti-H chamber inflammation, and they say, sir, I am having pain for 2 days, 3 days. So that might be because there may be a ciliary body inflammation. So better to go give a homide for 5-6 days and then basically stop it as per the patient's convenience. So I would, just interest of time, would not show you the videos. This was a case, one of the case which I want to just let you know is a 26-year-old medical student, post VR surgery with silicone oil, secondary glaucoma, PL positive vision, almost total optic atrophy, painful eye. So the best case to do a DLCP or a cyclocryo. In this case, we should. I first said that because I was not having a DLCP, I said that we can go for a cyclocryo, or you can get a DLCP done in any of the other institute. But he said, because he's a medical student, he said that I would not go for a cyclocryo and I would not go for a DLCP, because the chances of phthisis are there. So one thing that I have seen is that we have not got, fortunately, any phthisis or any hypotony. Maximum is that we have not got any IOP reduction, but not these things. So I said, okay, we can go for this. One thing is very important is that when you are doing it, please do a gonioscopy and see if there are silicone oil. Still, sometimes silicone oil globules are there in the trabecular meshwork. So what I did in this case was that I basically did a good AC wash also, decreased the pressure. So the best micropulse works, does not work at very high pressure. So if you are having a 45, 50, 55 pressure, it doesn't work at all. The thing is, just decrease the pressure by 20, let's say the pressure is around 25 to 30, then it works better. And very high pressures, it doesn't work. This is sir have given it, so it's not something, and you see that after doing, because you have to pull up the cases, you basically put 7 cases and out of them 3 or 4 would come, and you see that this probe, there may be some issues with the probe also. You can get a burn of the probe also. So whenever you have done first case and now you with the same probe you are going to go for a second case, please see the probe once that it is not damaged. So results are for 3 months with the older probe, they were better. As soon as we go to 3 to 6 months, they decrease by 50%, and 6 months to 1 year, they decrease by more 50%. So actually, the success, if we say that 60 to 70% in 3 months, goes to 10 to 12% in the after 1 year. Question still not answered. Their efficacy in childhood glaucoma, their efficacy in uveitic glaucoma, And they say that you can do it in controlled glaucoma patients as well. Let's say the patient is on one medication or OHT. So I have never tried, and I would never basically tell to try it in these patients. Two of my patients who are myopic patients where we have done it, they have got persistent dilation, and that is a very bad thing that is happening, because now you cannot, these are the young patients, and you cannot give pilocarpine throughout the life for this thing which you have done. Sequential micropulse laser, then again it is 50-50. In 3 cases we have got again 2 or 4 millimeter of mercury pressure reduction. In 2 cases we have absolutely no reduction of pressure. I have not done more than 2 in most of the cases. In same happening with the keratoplasty cases, and same happening with the NVG cases. So only one thing is that initially when I started it, so when I was doing it superior one, I thought that there is some hypotony or some pressure reduction which is happening on the table itself. So that is very important, because if you are putting a corneal traction suture, after that you should not perforate the cornea, because if the pressure goes itself down, you are thinking that the pressure is high, and suddenly your corneal traction suture that goes into inside, and now you are making it an extraocular surgery and intraocular surgery. Okay, sir. So the next thing which we would be talking about, endoscopic cytophotocoagulation. So endoscopic cytophotocoagulation, again a cyclodestructive procedure. We use a laser and we use an endoscope, and there the mechanism was to increase the uveous scleral or outflow mechanism. Here the mechanism is to basically do the destruction. Just my last point here is that whenever you are doing it, it is not something which cannot go into hypotony. Actually you are doing a total destruction. If you are doing it 180 degrees, you don't know which eye is faithful to you and which eye is not faithful to you. So only thing is, in Western literature they have also written that they are doing it with eye stent, and in those patients who are doing the retina surgeon is doing a vitrectomy also. So with the vitrectomy they can do a endocytophotocoagulation also. Still I would not basically recommend as the first choice of procedure in most of our cases. Thank you. Ma'am, endocytophotocoagulation, micropulse, yes ma'am, it can be repeated with a pinch of salt. Yes, ma'am. Ma'am, actually the thing is that it should not be your first choice. Now, sometimes the patient, the one patient I did, and he said that my... Huh. Yes, ma'am. No, I would not recommend, ma'am. Even after first failure, if it is not working, then it is not. If it is working for 6 months, then I would recommend it to do after 6 months, but not after 1 year. I would not recommend to repeat it, ma'am. I would not recommend to repeat it.
One interesting thing that we have noted is like failure. So we've done a number of cases of NVG or end stage glaucomas. So I think a wrong selection choice, probably we shouldn't have done it. But one thing that we've noted is all these patients come back, IOP is still high, but the eye becomes quiet.
Yes.
I can't explain what's going
Even
on.
I cannot explain, sir.
But the patient is like, Dr. Babu, khub bhalo hoyeche, you've done a wonderful procedure, but I'm seeing the IOP is 50. Yeah.
Yes, with the cyclocryo also, the pressures are same, but the patient says psychologically whatever that I looks whiter.
So probably something is going on.
Okay, thank you, sir. Thank you very much.
Vineet. We would have a lot of questions and a lot of discussion if there were a lot of other people there in the hall. So I'd move on to Siddharth. I've saved the best for the last. So now that Siddharth is gradually evolving his techniques of MIGS, especially GAT. So every time I'm coming to one of his talks, there's something new. Today also I saw one of the views of GAT, which I've never seen before. It's such an amazing view that if you can have that kind of a view, although I think technically it's going to be difficult because there'll be another person doing it, but it was one of the best views I've ever seen. So Siddharth is going to talk about MIGS and how it's developing, and in the Indian context, where do we really stand? So over to you, Siddharth.
Thank you, Arijit, and it's always a pleasure to meet you, talk to you, and so happy to be here, and thanks for getting me up here. So when we talk of MIGS, we should always give our pranams to the God. It is not intended to replace trabeculectomy. That we have to remember. Trabeculectomy is the most efficacious surgery for glaucoma, and when you want IOPs in low teens or a patient has advanced glaucoma, this is where you go. However, like any surgery, even Sachin Tendulkar had weaknesses. So, like any surgery, TRAB also has issues that can come up over a long-term follow-up. And these bleb-related problems and hypotony is something that we can do compensate for by performing these MIGS surgeries. Now, MIGS, there are multiple surgeries. So basically, you can divide them into bleb forming surgeries and non-bleb forming surgeries. And I will try to concentrate on the surgeries that I have done and is easily available in India. We have already covered ECP, so I will probably be talking about the Schlemm's canal surgeries only. And the surgery that I have maximum experience with is gonioscopy assisted transluminal trabeculotomy. And what you see here is surgery being performed for a phakic eye. The suture insertion is performed, the side port is made at about 90 degrees from the site of intended goniotomy. I am putting pilocarpine because I don't want to go touch the lens. It's a clear lens. And the side port that I make for this MVR blade for goniotomy is right opposite the nasal side, which is gives you the best access. I always use a cohesive viscoelastic or a gel for the intracameral and dispersive viscoelastic on the eye. So everything has to go in first before you put the gonio lens. This is because after gaining some experience, you are confident that you will not struggle with the view. So once you are used to it, you can get the view immediately. And I'm incising the top of the trabecular meshwork with this MVR blade. And once that cleft is created, then I'm just, what you can see is pushing the suture in. And when you push the suture in, you always have to remember that you go towards the angle first and then go forward. Towards the angle first and then go forward. And this will give you the ability to push in almost 1 complete clock hours of the suture at one go. And within 12 to 15 strokes, you will have the suture coming through the other end. The resistance does increase when the suture crosses the 180 degrees opposite side, because the vectors of the force change. You should be feeling some amount of resistance while you are doing it. It should not be resistance free. If there is too much resistance, then you can probably move on from 5-0 to 6-0, or if you are using 6-0 already, then smaller tip of the suture, because you don't want to damage the thing and just come back without. So once the suture comes out of the other end, just pull it over the top and then you rip it. So this is an unedited video of a GAT. It is just played at twice the speed. So once you are experienced, you can finish the procedure in 5 minutes or so, if you remove the time that is required for injecting pilocarpine. So I will just share with you the results that I have over the last 1.5 years that I'm doing GAT. 17 patients completed follow-up for 1 year, and 83 eyes have follow-up for 1 month. I'm telling you both because I want you to know the long-term also, but I also want to let you know that I'm not hiding something by not telling you the short-term results. It does come out that as we are expanding the indications of doing GAT, I am meeting more failures. So earlier I was very carefully selecting. Now we are quite confident that it works in all multiple scenarios. And I will tell you where it doesn't work in my hands. So 4 patients needed additional surgery. 1 patient needed TRAB in both eyes. She was a young POAG patient, and within 1 month the GAT just failed. The first day IOP was good in both eyes, but then 1 week onwards the pressure was in 30s and 40s, so not responding to medication. 1 patient who already had a phacotrab earlier underwent GAT, again worked for 6 months and then failed. There is one patient with uveitic glaucoma who needed goniosynechia because pus formed. After goniosynechia, again the pus has reformed. I did an iridoplasty for this patient. His pressure on the day when I did iridoplasty, before coming back, it went down. But the patient will come back again on Tuesday, so I am not just keeping my fingers crossed. So if you look at patients who have followed up for 1 month, you see only 3 patients are on medications. So and if it works for 1 month, it is most likely that it will work in the future also. And if you look at the intraocular pressure distribution, all of them are 78 out of 83 are under 21 millimeters, and 41 are below 14 millimeters of mercury. So this is a mix which can work well for certain section of patients. You typically expect an IOP of between 16 to 18, but some patients do better also. And this is the 1 year, 17 patients who followed up for 1 year, 13 are not on any medication, 16 have intraocular pressures lower than 21, 7 of these lower than 14. And I already told you 4 patients needed repeat surgeries. Now, 2 patients where it did not work, I am counting the goniosynechia patient also in this, is uveitic glaucomas. They were both open angle glaucomas, but it did not work for them. So I don't know what is happening. POAG works well. It is very well established. Intraocular pressures are also good. JOAG works in all the 7 cases that I have done. Very interestingly, in PACG, the 11 cases that I have performed, the only 1 patient has follow-up of less than 6 months, and all of them are working well. Now, when the angle is not completely open, or I don't do a GAT, or sometimes it's a mixed thing. I sometimes do a bang also. If the target pressure is not lower than early teens, not lower than mid-teens. So bang I always combine with phaco, and I used to make a goniotomy first before doing the bang. But nowadays I realize that it's better to go to reach the Schlemm's canal and then just rip out the strip. The goniotomy may make you go behind and just making an incision rather than taking out the strip. So you can see that strip here, and I try to perform at least 5 clock hours of goniectomy. And these are the very short-term results of the 60 eyes that I have done the bang procedure for. And there is one patient who had a bang done alone. She is a patient who has had a TRAB, who has had an AGV, and the pressure was still high. So for 2 months now, the pressure without medications is 15 for her. And 11 patients have intraocular pressures less than 16, 6 of them less than 14. So bang seems to be working well, and it is a 5-minute procedure. I'm so happy when I don't have to do a GAT and I have to do a bang. I've become lazier and lazier. KDB, this is, I'm just sharing Rashmi's video, who has this amazing video here. And looking at this video, I could not show this video. So this was beautiful. So KDB has a very, very sharp edge. And instead of just making an incision, you can take a strip out, and that strip really will open up the Schlemm's canal for the aqueous to go through. And you see a very, very wide and nicely defined cleft here. And when we followed up these patients for a short term, they were all working in these for 6 months. Now, this is what the international data is. It's very important to look at this. So any surgery which is closer to this part, it means that that has ended up with a very low intraocular pressure. Now, which are the surgeries? iStent has ended up with low pressure. Zengel implant has ended up with low pressure. GAT and trabectome, these are the surgeries which have ended up in low pressure when performed alone. When performed along with phaco, it is only GAT and trabectome which have done well. And if we compare this, the starting point for iStent and Zen is quite low, much significantly lower than what it is for GAT and trabectome. So if you want significantly lower IOP and your starting IOP is slightly higher, you would rather do a GAT and trabectome rather than a eye stent. It will not take you very low. Now the advantage is obviously you cannot have any post-op interventions to lower the pressure further. Massage will not help, or God knows, maybe helping. Hypotony and blood-related complications can be overcome. Now, there are disadvantages also, and there has to be a match between your expectations and the reality. So don't expect it to get you pressures of 10 to 12 on a regular basis. That is not going to happen. And some patients, it will not work. Like I'm not going to do it for uveitic glaucomas because clearly it is not worked, and talking to my colleagues, it doesn't seem to be working well for them also. So there is a learning curve involved. You need high quality microscope, slightly expensive instrument. The Grishaber forceps itself is expensive for these procedures for GAT, and KDB is expensive. So if you don't want to use KDB, you have an alternative in bank. If you don't want to use an Omni inject or the eye track catheter, you have a 50 Prolene suture which you can use for GAT. I will just summarize the recommendations here by looking at the eye stent, KDB, bang and GAT, which are the procedures that are available for us on these 4 different parameters, and rate them from 1 to 3. If you look at it, the eye stent is the easiest to do, but it is more expensive and least efficacious. So if you want lower pressure and you want to do something for angle closure, the KDB, bang and GAT are the options that you can look at. Eye stent is contraindicated in patients with angle closure. I am very, very excited for these 2 devices to come to us, the Zen implant and PressureFlow, which was in focus earlier. In focus especially because it seems to be working really well, no hypotony. Most patients will have pressure of between 10 to 16. So let us see when we have it and how it works in our population. And I will just conclude here. Thank you, ARIJIT. Thank you.
Thank you so much, Siddharth. Lots and lots of questions. I mean, I have a lot of questions. I mean, like, if GAT is working so well, why are you looking forward to the PressureFlow or the Zen?
Look, GAT, as you see, it doesn't work for everyone. It doesn't work for everyone, and a significant number of people have pressures between, say 16, 17 to 20s. Now, these are not the pressures that I will be comfortable with when a patient has advanced glaucoma. I will probably put one more medication. So those are situations, those are patients where you want IOPs lower than say 14, 15. You can end up there with GAT. As you saw, 41 patients out of 83 had pressures like that. But it also means that 42 of them did not have pressures like that. So we need something lower. And the other thing is, there is a chance that you can have bleeding inside the eye. So that is a fear that has not left me, and I still wait for the time when the patient will come back tomorrow, especially now when we are doing more and more topical cases. So their eyes are open, it's not patched. So when they come the next day, I'm just waiting to see if it is still clean or is there a bleed.
Now you're doing GAT under topical for all patients, like
no. But any patient who is good for topical phaco is good for topical GAT also.
Is good for. But during your learning curve, do you prefer topical?
No, absolutely. During your learning curve, the posture of, look, when I start now, I know where the head has to go. I have to minimally adjust. But when I was learning, the maximum time was taken in positioning and visualizing. Was not happening. Yeah. So that's the problem with all angle-based surgeries, that you need to develop that skill. And that is why the recommendation that our fellows have to do it for 20 patients in cataract surgeries that they have done. Visualize, go touch the angle and show us the video. With a Sinsky or a iris repositor, go touch the angle, don't damage it. That is also important. So do you have that much control that you can just touch the angle, kiss the angle and come back?
And Siddharth, how are you choosing the patients for bang and gap?
I am a little reluctant about bang. I was doing a webinar with Dr. Malik Kahook, who has developed the KDB. So I was sharing my results of bang with him. So he said they have actually gone through this process and these will work really well to start off with, and then suddenly you will find them at 1.5, 2 years later that they suddenly stop working. So I have that reluctance when I don't have any other option, where basically there is extensive pass, then I do bang, and that is why it's all only in angle closures.
How many of your patients have you come across with, significant hyphema post-op with after bang or GAT?
I will show you something. This is something that I have submitted for a photo essay. So I have never needed a procedure for any of the hyphemas. But if you see, this patient had a very significant hyphema when she started. Immediately after surgery, look, this was the worst case that I had. It's probably the connector. Okay. So this was the kind of hyphema that she had, and this was really bad. I was so scared. I was supposed to leave for vacation. I told her that you come and get a AC wash done. I will go into the OR after the OPD and do it for you. But then she was reluctant. She said, "Doctor, can it settle on its own?" And every time she came and I advised AC wash, pressures were fine. And as soon as the visual axis became clear, she was seeing well. I would show her the photograph and say, "This needs to go." She would say, "Doctor, can we wait for 1 more week? Doctor, can we wait for 1 week?" That is how we waited for almost 6 weeks for her. And though her pressure was still fine, we ended up with something that is not described, and that will make me go do the AC wash for this patient. Do you look, the inferior mirror, superior angle, you see a cleft there. But when you look at the inferior angle, you see this pus has formed. This is fibrin membrane which has caused formation of pus here, and this can also happen, and that is the reason now if I see a major hyphema that has not cleared it within a week, I would recommend that you go and wash it off. So you have ASOCT images of this also. So you see this membrane beautifully here. So through this membrane you can, so that can be an additional reason to not let hyphema be there for more than a week, 10 days or something like that.
And what about any preoperative anti-glaucoma medications which you would consider stopping? Or for example, like in the post-bang cases or post GAT cases, what do you feel once they start failing? Is it so that some of the medications don't work as well as in a angle in which you have not done any angle procedure?
I think it is true for all surgeries. So when you have performed a trap and it fails, you typically, the medications can't bring it back to the same preoperative level. But it's not very different from usual thing. I think because I have not, if it fails drastically like it did in 3 patients that I showed you, there it didn't work. But for most of the others, there are patients who are working on medications also. But the experience, as I said, is not very extensive. We need to follow up over long term. We have a keynote speaker amongst us, and I think I'll just step down from here.
Thank you so much, Siddharth. So it was a pleasure, as always. So, keeping in view the discussion which is going on, Dr. Prithvi is going to present something on smartphone gonio imaging. So I think Siddharth is going to be very interested because it's all about the angle. We've talked a lot about the angle. Thank you so much. So let's have this keynote address.
This is a device which I have made myself. It's using an intraocular lens which I'll show you how to prepare. So you can do it by yeah, ASPI, yeah, something. Yeah, I'm the same person. Uh, so I'll be talking about smartphone gonio imaging. So as we all know, glaucoma is the second most common cause of blindness and leading cause of irreversible blindness, with prevalence of around 11.9 million, in equal proportion of primary open angle and primary angle closure glaucoma. So as we all know that population studies in India have proposed periodic screening of high risk population for diagnosis of the disease at an early stage, and imaging of the anterior chamber angle with gonioscopy forms an integral part of this glaucoma screening, diagnosis and management. But as we all know that it is very much limited to the slit lamp, because without the slit lamp gonio imaging is not possible. And recently there are few, actually only one article which showed the use of smartphone for gonio imaging. So over here I would like to describe what I have made. This is anterior segment photography with intraocular lens, that's this ASPI. So this is basically what I was using to image the anterior segment without a slit lamp. So we don't really need a slit lamp to image the anterior segment, and this is how I have done it. So we use a chart paper of 10 centimeter to 1.5 centimeter. Once we have cut it with a scalpel, we fold it and mark the area where we want to keep the IOL. And inside this, we add a double-sided tape and we punch with a paper puncher, we punch one hole. And for the gonio imaging, we use a 6, 8 or a 10 diopter lens. So what I've used here is either a 6, 8 or a 10 diopter lens, and with the flashlight on we'll have to take the image. So we take a video, and then from the video we take the image, and this can be done with any phone, preferably a phone which has the side camera, the camera which is in the corner, because the thing is, the problem is in gonio imaging your nose comes and hits, so that is a big problem. So we did this in our in Arvind Hospital, Coimbatore, with 120 patient over a month, and so we used. It was a very routine examination, the way we do it in the slit lamp, except that we don't use the slit lamp. That's the only thing. So we used. So I'll show you the images. So this is how we use. We did it by making the patient sit on the slit lamp for stability, or if there is no slit lamp, we made him we did this with patient just sitting just like that, even with lying down, even with the retinoscopy slit also, we use a slit to replicate the way we get images in the normal slit. So these were the images that we got using the ASPI gonio. So you can see how clearly you can actually see these structures, and this was the one which we got using the retinoscopy slit and the ASPI gonio together. But the problem over here is we need another person to actually focus the slit to the angle. And over here you can see this is the principle, basically more or less the same thing, just that we are using the ASPI gonio here. So here you can see this distance reduces as we increase the IOL power. So this is 6 diameter, then this is the 8 diopter, and this is a 10 diopter. So as you can see, it is reducing. So anything more than 10, you will actually hit this flange of the gonio lens. And these are the corresponding images that we have got. So you can see as we increase the IOL diopter, the magnification also increases. And the last row, okay, you can see these are all the images taken from different lenses. So single lens, 3 lens and 4 mirror, mirrors. So single mirror, 3 mirror and 4 mirror. And we actually found out the 8 diopter IOL with a single mirror could actually give very good images. So that is what, and this is a comparative image. This is a slit lamp image, and this is the image which we have taken from the smartphone. Is the Aspigonio. These are also images of the slit lamp with the Aspigonio. These are all the same. So the one on the right is actually the slit lamp image. So we graded the image, and we found we found it to be very comparable to the slit images. So you can see 92 and 78. So this is according to this grading. So we have noise, sharpness, contrast, diagnostic confidence, artifact, and blotchy appearance. So 1 being the minimum and 5 being the highest. So with this, we graded all these images, which was randomly put and given to grade, and we could see actually it was almost comparable to that of the slit lamp. Also, we graded the angle according to Schaffer's grading, and actually we ended up diagnosing around 4 patients as angle open because of the pupil constriction because of the smartphone light. So, but the main thing over here is we can use this as a screening tool at places where slit lamp is not available, where we are not able to reach. So there is a need of a compact health monitoring system, especially in small clinical setups such as peripheral health centers. And this was first of its kind of study using this as we go new. Thank you.
How did you come up with this? What made you come up with this idea?
Actually, my first innovation was the red cam, the trash to treasure red cam, which I did using a hand sanitizer bottle, which I converted
I
into
saw
a red
that
cam.
in the TOT competition, one of your residents
Yes.
was presenting.
Yes, yes. So then later on, actually, my mom said, "Why are you presenting the same thing everywhere?" I was like, it's difficult to do even one innovation. But then I actually took up it as a challenge, and I'm actually good with photography. Photography is my passion. So I had a little bit of the knowledge of how lens works. So I thought, why not use this IOL? It's actually like a magnifying lens and a macro lens. So I used IOL, which was actually expired IOLs, which we get to take the anti-segment images. So eventually, I thought if I could take anti-segment, I could actually do anything which the slit lamp is used for to magnify. So just thought maybe we should try doing Gonio too. But then slowly, when we see, it was not. It was very difficult because we used to use 15, 20, 25 for anti-segment. So those are all the higher powers. So when I used to go, it is to always go hit the flange. And slowly I thought, okay, we should reduce the IOL power. So we started reducing to almost, we started from 5, 6, 7, 8, 9, 10, 11 till 15. We used everything, we trial and error, so a lot of times we did. And eventually we found out that this one was the best, image which we got. The only issue over here we are trying to solve is about the light, because as you can see, those 4 cases we could actually miss because it could be wrongly graded. But at least we could actually go for screening, because places where there's nothing else we can use this. And those 4 cases which are in the border, we can actually send them to the base hospital to get it fully evaluated.
But being Arvind, you have to be.
I'm using the PMMA rigid lenses, which I use with 6 diopters. 8 diopters, sorry. 8 diopters IOL.
Being Arvind, you have to be careful, because if you go tell a patient that everything is all right,
Huh.
so we have to be very careful, and with what you said, the 4 cases, because those 4 cases you got because you did both examinations.
Yeah.
So before screening and before promising that this will screen and pick up all the angle closures,
Yeah.
we have to be very
Very careful.
Yeah.
But at least we could actually diagnose these, because otherwise we wouldn't have checked the angles of these patients. But now we have a alternative, and we could actually get these 4 patients to the to get it properly checked. Oh, those ones in the borderline, like who, if we feel that Schaffers 1, 2.
Excellent.
Yeah, single mirror is, and this one works really good. Yeah, yeah, maybe sometimes.
In fact, for gonio photos, we have also started using a two mirror
Single mirror. And I don't know, I've used, and other people who are using, who I used to send to, take the comparative images, they have said the smartphone gonio imaging was much easier than the slit lamp. And now one more hack is that, the if the gonio lens and the mirror is here, you go with the phone from here. Okay, you don't go from here or here or here, you go where the mirror is. And the video, another hack is that when you go from this side, before the pupil constricts, you would actually record the actual angle too. Not every time, because sometimes it takes time to focus, that time you will miss. But when it's already focused, when you go inside, you can actually see the angles opening, and it is video recorded, and you can actually go back and see what the actual grading was.
It will be very, very interesting to look at those videos.
The light source is extremely powerful, so that has
Yeah.
to be you have to be
Yeah,
very careful.
we
It's
can
very
actually
amazing.
reduce it using a micropore or
Yes,
something like that.
probably something.
Yes.
So is the next thought about looking at the fundus? Are you already thinking, because now you are gradually going in?
Yeah,
So maybe
but
something.
yeah, eventually, I think there's
It's amazing.
already a instrument called peak retina, which
Yeah.
is almost like this.
Yes. That is
Yes.
very similar.
But the thing is, actually, this whole method is done in such a manner that even you can go home and make your own SP gonio and start taking images. You can compare it yourself, or maybe if you have your kids, you can just tell them, just make this, and they'll. It's more of a craft work.
And for the
Anybody can do it.
yes, anterior segment photographs,
Yes.
it's a 20 diopter. you were saying?
15 to
15
25.
to 25.
15, you'll get the whole of the cornea. The whole cornea, the whole field, you'll get the whole cornea. If you go to 2025, you'll be more focused to a particular point in the cornea. If you have a particular foreign body at one place, if you put 25, you will get it so beautiful image. I don't know if so I have an image.
You're done with the presentation.
Yeah, I just want, I'll bring the laptop back.
No, I was wondering if you started getting up, clicking on photos while your presentation is going on. That would be. We need to take care of tomorrow.